So stillbirth or single intrauterine demise in twins. Okay, don't worry, I'll use fine. So at least in the UK, I mean, in general, everywhere in the world, obviously twins are rising because women are getting older and wider use of IVF or assisted conception techniques. But despite that, it's still, at least in the UK, it's about twin pregnancies contribute about 2% of the births. In fact, in 2015, it was about 16%. But despite that, they contribute to 7% of stillbirths, 18% of neonatal deaths, and the risk of cerebral palsy is 6 times higher in twins compared to singleton. And therefore, you can see clearly from these figures that multiple pregnancy are disproportionately overrepresented in stillbirths, neonatal mortality, and cerebral palsy. And again, this is UK figures. It's not the most recent one. So singleton stillbirth is about 1 in 200. The most recent is about 1 in 240. Twins is about 2 or 2.5 in 200, and triplets is about 6. So you can see it's twice or 3 times in triplets. But it's not just the mortalities, obviously the safety incidents, the medical legal claims, the financial cost is certainly rising, not just in the US or the UK, but everywhere. And a lot of them involve multiple pregnancies. So this is again UK figures, and you can see that in singleton, the stillbirth rate has been static. It's about 5 in 1,000 for a number of years. In twins, initially gone down, but certainly around 2014 or just before 2014, it actually was increased. Probably this is the most important slide in this talk, is this head and mortality of monochorionic twin, and this concept that I think many people are not necessarily familiar with, or certainly I only learned it when I started doing a lot of twins, is the fact if you look at the monochorionic twin pregnancies compared to dichorionic twins, and if you look at the perinatal loss, the figures in the bottom, you see that actually it's about 2.8% in monochorionic versus 1.6. So a little bit more, but not a lot more, yes? But actually, if you look at the fetal loss, the early losses, 12% in monochorionic twins and only about 2% in dichorionic twins. And therefore, the majority of the losses that occur in monochorionic twins occur early. They don't necessarily feature in the perinatal loss rate. They're actually intrauterine demise or fetal losses. And this is what Niels Sapir published in 1997 to say is the hidden mortality of monochorionic twins, because it does not necessarily feature if you just look at the perinatal mortality, because they die or the losses occur early. And when we looked at that was the Stork data, again from where I work, very large cohort of more than 3,000 twin pregnancies, and you compare the losses between monochorionic and dichorionic twins. If you look at the top graph on the left-hand side, you see that the red is the monochorionic and the blue are the dichorionic, and after 26 weeks is about maybe twice, but it's the same. Yeah, all through until the end of the pregnancy. But actually, if you look at the table on the bottom, and you look at the loss early, so between 14 weeks and 24 weeks, and this is our 2 gestational age weeks blocks, and you compare the losses in monochorionic, the red versus the dichorionic, the blue, and you see the odds ratio or the hazard ratio, you see is much higher in monochorionic versus dichorionic. So 16 weeks, 20 times higher. 18 to 19 weeks or 18 to 20 weeks, 32 times higher, 17 times higher. So the losses are much, much more in monochorionic than dichorionic, mainly early in pregnancy. Once you reach 26 weeks, it's about twice. So why? Why do you think? What happens between 16 and 24 weeks? TTS. Yeah, so TTS is the biggest player, I think, contributing to significantly higher loss rate, fetal loss rate in monochorionic twins. So back again to the UK where I work, and stillbirth rate, this called Embrace report. It's published every year, every couple of years, and they look at all the perinatal deaths that occurs in the United Kingdom. And the one that was published 2015 reported that actually the stillbirth rate increased in multiple pregnancy by about 14% between 2013 and 2014. A conceded that was published on the same day as the Ministry of Health was actually came up with an agenda or a target for the UK to reduce our stillbirth rate by about 50% by 2030. I guess it's questionable whether we'll be able to achieve that. But when he did that, in the UK, there has been a national effort to try to reduce the stillbirth rate in this country. And they come up with something called Stillbirth Care Bundle. This is just a proposal to reduce the attempt to reduce the stillbirth in the UK. And it has 4 components. One of them is smoking cessation. Another one is identifying and surveillance for fetal growth restriction. And they suggested, the initial version was suggesting using of this GAP or growth assessment protocol, which basically using customized charts for monitoring fetal growth. And then the third component was improving awareness and active management of reduced fetal movements. And the fourth component was fetal monitoring, so improving training of the doctors and midwives to interpret CTG, which is great, but none of them are twin-specific, really. So we were not happy, and we published a report to sort of criticizing this. And in the report, we actually quoted some of the UK data. It's quite old data, but it was published, national data, to say, well, look at the causes of stillbirth in singleton pregnancies compared to twins. And you see they're actually similar. The list is similar, but except for the red part of the chart, the pie chart, which is the specific fetal condition, which is only about 2% in singleton, but about 21% in twins, and a large proportion of that will be twin-to-twin transfusion syndrome. So we published this report with TAMBA, with a national twin charity, to say, well, criticizing the stillbirth care bundle and say, well, actually, these 4 components, none of them really, or the 3 of them don't apply to twins, because in fact the evidence that support potential causal relationship between smoking and stillbirth usually actually stems from studies that excluded twin pregnancies. The GAP, or the one that was system that was proposed to monitor the fetal growth, again, there's no evidence that it works in twin pregnancy. There's no single study that included twin pregnancy. And in fact, the reduced fetal movements, again, most of the studies that linked reduced fetal movements with stillbirth also included only singleton pregnancies. And in fact, if you look at the RSOG, this country, Royal College of Obstetricians and Gynecologists guideline on reduced fetal movements, and you look at the first page, it clearly states this guideline excludes the management of reduced fetal movements in multiple pregnancy. So they told us, so what do you want? So what do you expect? What do you suggest? What do you want us to do? So we came up with a modified stillbirth care bundle in multiple pregnancy, which include specialist care and early referral, which is the protocol that I showed you, that actually we have a system by which these pregnancies are monitored, train people how to do it, and identify these pregnancies early and refer them to the specialist. And delivery of uncomplicated twins, dichorionic at 37 weeks, monochorionic at 36 weeks, and triplet at 35 weeks, which is according to the NICE guideline, and I'm going to show you the evidence behind that. And of course, fetal monitoring is always important to train people how to interpret CTG. So that applies to twins as well. And we've been working and lobbying and sort of doing some initiatives with TAMBA, with a charity, to actually try to reduce the stillbirth in the UK. And in June 2018, the same report was published, the EMBRACE report, looking at the stillbirth rate in the UK. And for the first time in this country, there's been unprecedented reduction in stillbirths in twin pregnancies by 50%. And not just the stillbirths, but also the neonatal deaths reduction by 30%. So that's great. So despite Brexit, that's actually great. Okay, so what are the causes of stillbirth or single fetal demise in twins? Well, some of them are very similar to singleton, and some of them are quite unique to the twinning process. So they're similar to singleton, of course, genetic abnormalities or chromosomal abnormalities, placenta insufficiency, infection, abruption, cord abnormalities, or maternal disease. They are the same for singleton or twins. And the ones that are unique to twins, obviously twin-to-twin transfusion syndrome, selective fetal growth restriction, which tend to be more common in twins, but also quite more unique, especially in a setting of a monochorionic twins. Twin taps or trap or conjoined twins. The vanishing twin, which was a question earlier, which is essentially really what I mentioned when I answered the question, that is, in fact, is more common than what we expect, just because we don't really scan a lot of the pregnancies very early. And in fact, a lot of the times the outcome is very good. And the main thing is that it could actually cause vaginal spotting. And just be careful about the potential false positive result in using self-Reginae or NIBT because of the vanishing twin that you don't know about. The outcome is a complete reabsorption, or actually this fetus papyriaceous, which is something that you can see if you look at the membrane in the placenta after the delivery. Or sometimes you may actually come across it as a placental abnormality, maybe a cyst in the placenta that often of no clinical significance. Again, I showed you this slide in my talk in the morning about the ISWA guidelines, which is if you have a single intrauterine demise, how should I counsel these women? And I quoted you some of the figures from meta-analysis about the risk of demise of the co-twin, the risk of preterm delivery, risk of brain abnormalities or neurological abnormalities. And you can see clearly that the risk is higher in monochorionic compared to dichorionic, except for preterm delivery, which is very high in either twin. But we wanted to be a bit more sophisticated in our counseling. So does actually the risk of preterm delivery varies according to the gestational age at demise of one twin. So again, we looked at the stork data, which is quite large data, and you see on the graph on your right-hand side that actually the risk of preterm delivery varies significantly according to the gestational age. So if it happens in the first half of the pregnancy, the risk of preterm birth less than 34 weeks is much less than if it happens later. So the later the demise occurs, the higher the chance of preterm delivery. And again, I showed you this algorithm about how do you manage single intrauterine demise in a monochorionic twin pregnancy, and the fact that it needs to be referred to fetal medicine center, detailed scans, doing Dopplers, and following up this pregnancy every 2 weeks. Consider MRI 4 to 6 weeks after the demise, and then delivery at 34 to 36 weeks after a course of steroids, which is controversial. Yeah, so some people would say, okay, well, if the pregnancy is fine, particularly if the demise occurred early. So if you have a monochorionic twin and single intrauterine demise at 14 weeks or 13 weeks, and you follow up the pregnancy and everything is fine, do you really have to deliver at 34 weeks? Yeah, it's controversial. I think some people do, some people don't. But there's no evidence to back up. So how do you determine the need for intrauterine transfusion in these cases? Well, you should do detailed ultrasound assessment and try to figure out when the death occurs. Is it occurred within the last 48 hours, recently, or it's actually occurred a week ago? And how do you do it? It's not always easy, but you look for signs of recent demise. So looking for edema, ascites, pleural effusion, Spalding sign, for example. If you see Spalding sign, the death occurred a while ago. It's not in the last 48 hours. And then obviously you look at the surviving twin and assess whether this baby is anemic or not, and for any potential complications. So like if there's brain hemorrhage, for example, or signs of heart failure or hyperdynamic circulation, and we tend to use or rely on the MCA, peak systolic velocity, to diagnose fetal anemia in this fetus. So if you have a single intrauterine demise within the preceding 48 hours, so recent, with MCA peak systolic velocity above 1.5 mom, so this baby is anemic, in this case you do intrauterine transfusion. This is IUT, not IUD, intrauterine transfusion. And then you repeat the Doppler in about 5 to 10 hours later. If the baby is still anemic, so if the peak systolic velocity is still high, above 1.5 mom, you should consider repeating the transfusion. If there is polyhydramnios, for example, that was secondary to TTS or undiagnosed TTS or acute TTS, check the cervix, transvaginal. If it's less than 20 millimeter, you should consider doing amniodrainage. Because you remember I said the risk of preterm delivery is quite high. In fact, in these cases, certainly if it's like 28 weeks or beyond, we would consider giving steroids because the risk of preterm delivery is really high. If the single intrauterine demise was recent, so within 48 hours, and the peak systolic velocity is less than 1.5 mom, we will just repeat the Doppler within 48 hours, within 24 hours, and if it becomes anemic, we would consider intrauterine transfusion. Because perhaps the demise occurred very, very recently, and you're just seeing it before actually the baby becomes anemic. And again, the same rule about the polyhydramnios. Check the cervix, less than 20 millimeter, should consider amiodarage. If the demise occurred a while ago, so more than 48 hours, and there is no evidence of baby fetal heart failure, you just expect a management irrespective of the MCA peak systolic velocity because it's too late. Doing transfusion is not going to necessarily be beneficial, but you're obviously taking the risk of doing invasive procedure. So suppose actually this woman was the first scan. You've never met this woman before. She never had a scan, or you don't have access to this scan, and therefore you don't know anything about her. You just came, they called you, there's a twin pregnancy, and she came with a single intrauterine demise. What should we do? Obviously, the first thing you want to determine is the chronicity. You want to try to figure out whether a monochorionic or dichorionic twin pregnancy because it affects your counseling and your management. And the other thing, you need to work out the gestational age. And then you need to try to work out the cause and the timing of the death. And we do that by doing the detailed assessment. So biometry, looking for abnormalities, looking at the Dopplers, looking at the Likor volume. So maybe if there is polyhydramnios and oligohydramnios, well, it's likely to twin-to-twin transfusion syndrome, even if it's difficult to determine the chronicity, for example. Obviously, counseling, and then you consider giving steroids because of the increased risk of preterm delivery. The really key message is that avoid unnecessarily early delivery. If the damage is done, it's done. So delivering at 30 weeks is not going to necessarily benefit this baby. If anything, you're just adding the extra risk of iatrogenic prematurity. And then often these pregnancies, we would deliver vaginally unless there is an obstetric indication for cesarean section. Really important to consider post-mortem examination to try to find out the cause, and placental examination. And obviously, postnatal assessment, because if this baby have increased risk of neurodevelopmental delay, you want to make sure you detect it early and put special measures to help the baby. We have another talk about the reduction, but actually, if you have a pregnancy, IVF, trichorionic, triamniotic triplet pregnancy, okay? And one benefit that we will discuss and go through it in details of offering selective reduction, which should be part of your routine practice. Any triplets, when you see them at 12 weeks, you should discuss. That's one option. And you discuss that because you want to try to reduce the risk of preterm delivery. And Elizabeth mentioned early because of the risk of cerebral palsy. What about if these pregnancies started as IVF, trichorionic, triamniotic triplet, and spontaneously one baby died, and now it's got dichorionic, diamniotic twin pregnancy? Is the risk also reduced or not? So is the risk, if this woman's risk of preterm delivery is reduced, similar to what you do when you're doing reduction, or is it different? And essentially this study did that. So they compared the risk of preterm delivery in IVF pregnancies that started as trichorionic, triamniotic, and some of them did selective reduction compared to the one that had spontaneous reduction early, so before 12 weeks in the first trimester. And you can see it's similar. So actually by having this reduction, whether actively or spontaneously, you reduce the risk of preterm delivery early is less. So I'm not sure it's a good thing, but it's, to some extent, you can have a positive spin to it. Okay, so you did a TTS, had TTS, and you did laser. And of course, you warn the parents about the risk of demise after the laser. And very common question, they say, well, there is a period that I need to worry about. You know, when is the maximum, when is the gestation age, when is the time that the risk is highest? And certainly from the study suggested the first post-operative week, the first week after the laser, 70% of the cases that have single intrauterine demise after the laser occur within the first week. Okay? Are there any risk factors for the donor demise? So when you actually counsel these women for the laser, can you be specific? Can you be more sophisticated and say, look, actually, I think there's a high chance of demise of the donor after the laser, so the women they have expectation, or not? And yes, there are. So the risk factors for donor demise after the laser for TTTS, if you have absent or reverse endostolic flow in the umbilical artery of the donor, if you have a large discordance of more than 30%, if you have a marginal or filamentous cord insertion, or if you have a lot of anastomosis during the laser. So these risk factors suggested a higher risk of demise of the donor. What about the brain abnormalities? So in the past, I think many people used to believe that actually if the single intrauterine demise occurred after the laser for TTTS, the risk of brain abnormalities is small compared to if the demise occurred without laser. Because to some extent, you dichronise the placenta. Yeah, you stop it. But that's not necessarily true, because this study was from UK, and they looked at the incidence of antenatal brain abnormalities on the MRI following spontaneous single intrauterine demise compared to single intrauterine demise following laser for TTTS. And you see that the incidence is similar. So the laser is not fully protective against the risk of brain abnormalities if there is a single intrauterine demise after the laser. So if you have a single intrauterine demise, what is the risk of brain abnormalities or cerebral injury? And this is the Dutch data. And they defined cerebral injury as one of this. And there's a long list. They're quite serious brain abnormalities. And they quoted the incidence about 25%, which is the same as I told you earlier in monochorionic twins with single intrauterine demise. The risk of demise of the surviving twin or brain abnormalities in the surviving twin is about 25%. So also, are there any risk factors for that? So a single intrauterine demise, are there any risk factors that makes the surviving twin at a higher risk of cerebral abnormalities or brain abnormalities? Yes. So if it's advanced gestational age, if the demise occurs later in pregnancy, the risk of brain abnormalities is higher. If the demise occurs after TTTS, the risk of brain abnormalities is higher. If the women end up by delivering early, whether she went into labor or you end up by delivering her earlier, the risk of brain abnormalities is higher. Okay? What type of brain abnormalities you see in these cases or you'll be looking for would be hypoxic ischemic, so periventricular leukomalacia, infarction, or injury to the basal ganglia, thalamus, or cortex. Okay, maybe some of us are very good in neurosonography and they can look for these brain abnormalities by ultrasound scan, but some of us will need MRI to detect these abnormalities. So there are the brain abnormalities in these cases. So on the ultrasound scan, we should be looking for ventriculomegaly, white matter injury, ischemic lesion, periventricular leukomalacia, intraventricular hemorrhage, or cerebral atrophy. Okay, so when should we deliver twin pregnancies? So if they are completely uncomplicated, no problems, we should deliver monochorionic diamniotic twins from 36 weeks, and we give them a course of steroids, but some other countries don't. Dichorionic diamiotic twins from 37 weeks and triplet from 35 weeks. Okay, you do come across women who say, I don't really want to be delivered early. I don't want to be induced. I mean, things are fine, the babies are good, the babies are growing, there's no problem. Why do you want to deliver me early? And in where I work in the UK, we have NICE guidelines, and the NICE guidelines said if this woman decline elective births, you should offer them weekly appointments with specialist obstetrician. You do ultrasound scan, you assess the biophysical profile, and you do gross scans every 2 weeks because of the risk of stillbirth. So this was the NICE guidelines, but in fact, we published this very large meta-analysis in the BMJ 2 years ago, when they had about almost 26,000 twin pregnancies. And what they did is that this clever analysis, when you balance the risk of stillbirth versus the risk of neonatal deaths. And when these two lines cross, would be the cutoff to recommend delivery, because that means the risk of stillbirth outweighs the risk of neonatal death. And you can see for monochorionic twins with about 36 weeks and dichorionic twins with about 37 weeks, which is consistent with the NICE guideline. We did heard earlier about the cord entanglement in monochorionic, monoamniotic twins. But when do we deliver monochorionic, monoamniotic twins? Well, the data obviously is much less because the numbers are less. And therefore, this Canadian study, they did similar analysis to the one I showed you earlier in the BMJ paper, which you balance the risk of intrauterine demise with the risk of neonatal complication, and the cutoff was 32 weeks plus 4 days. And therefore, that's the rationale behind the recommendation of delivering monochorionic, monoamniotic twins between 32 and 33 weeks. But it's still controversial. Not everybody does that, but I think the majority of people would agree to do elective delivery in uncomplicated MCMA twins at 32 to 33 weeks. Okay, so the take-home messages, obviously, it is a high-risk pregnancy. Be careful of the hidden mortality in monochorionic twins. When you counsel this woman, the counseling would differ from if you counsel her at 12 weeks compared to if you counsel this woman at 30 weeks, if you see her for the first time at 30 weeks. Well, obviously, the risk will be less because she's already past the gestation age where TTS usually presents. Avoiding stillbirth starts in the first trimester when you determine the chronicity and you make a management plan for the rest of the pregnancy. Be careful of twin-specific measures. Things that work in singleton do not necessarily work in twins. Okay, thank you. Okay, any questions? We've got 6 minutes, yes? But we have a talk. We cheated a bit, we're moving one talk. Okay, so any question from the floor? Okay, so we have some questions here. So Olivia is a very good friend, and she's now in South Africa. So unlike London, where monochorionic candidates for invasive treatment can be timely referred, your advice, patient abroad, early TTS, can afford flight or cannot afford. Not sure I understand. But I suspect what you mean is that if the woman have early twin-to-twin transfusion syndrome and she cannot afford or can't afford to fly, and if she can't afford to fly. I mean, it's a difficult one because I guess it depends where you work and what sort of what things you can offer, and it depends how far the nearest center, for example. So if you work in a country where maybe you don't have that facilities, but there is an hour flight or 2-hour flight to the nearest center, I think it would be sensible to do that. And I think from my experience, parents really value that, and they're happy to go. And even if you assess and you don't need to do fetal therapy, and it's not too far away, they actually appreciate that and say, fine, I'll be back, rather than doing unnecessarily fetal intervention that might lead to risk of miscarriage. That would be my rationale. But for example, stage 1 TTS, when you have severe polyhydramnios and short cervix, in this case, probably even if it's stage 1, you would actually do laser treatment. Does that answer your question, Olivia? Okay. And then there's another question from Michael. What's your view on routine prophylactic cerclage in triplets in IVF pregnancies? In Ghana, this is often done because of high cost of IVF as a desperate measure. Okay, so you're absolutely right. It's actually not uncommon that you would see women who had IVF and is triplet, and automatically in certain countries, for example, they automatically would put a cerclage. There's no really evidence to support that. It is still an intervention. So I think coming from with my evidence-based hat on, I don't think we should be doing something that's not evidence-based. But you have to acknowledge it. It's not an uncommon practice, so we see it a lot, I think. Lata from Pool, how do you monitor using CTG? Is there CTG machine that has 3 monitors available? That's an interesting question. So do we have CTG that's for triplet pregnancies? And the answer is yes. There is actually CTG machine that have triplet, but I personally find it very confusing, and most of the midwives find it even more confusing to monitor triplets. And I suspect that's one of the reasons they often have cesarean section. Yeah. Having said that, we had triplets who had vaginal delivery, but often the ones that come in preterm labor, 28 weeks, for example, and they come in preterm labor and they deliver the 3 very quickly. I suspect if we had time, we would have done cesarean section for them, probably. I think the woman is just fast. Okay, any other question or comments? Or maybe any comment for these questions? I mean, it would be nice to share your experience. Yeah.
No, actually, just for on the same subject for triplet.
Yeah.
I wonder whether the evidence we have, or the absence of evidence in doing circulage for twin applies for triplet, because these are quite rare incidences, and I don't know whether the evidence we have from whatever randomized studies include the triplet and the higher. Because in the part of the world that we work in Saudi Arabia and Sudan and so on, we have not only the triplet, we have quadruplets and so on. And for those, particularly in private practice, it will be very difficult not to offer. And most of them are IVF pregnancy, and they have been waiting for such type of pregnancy for a long time.
Yeah.
So you do whatever is possible in your hand, irrespective of the evidence.
Yeah,
sometimes.
I understand.
Yeah.
Yes, and I understand your point, but there's no really good evidence in triplets. And I think partially is exactly this precise point that you made, is the fact that the absence of evidence does not mean there's evidence of no effectiveness. It's just the fact that we don't know. We don't have evidence to say that it works or not. And therefore we tend to, rightly or wrongly, extrapolate a lot of the evidence from twins and say, well, in twins it does that, so perhaps maybe triplet. That might not be right, but certainly I think that's a common practice. And therefore, if you go back to the evidence on the cerclage, the evidence of prophylactic cerclage is very little, but the one RCT, the one that was a Cochrane, actually reported that the incidence of preterm births was higher, in fact, than the one that had prophylactic cerclage. So based on that, you probably could potentially be criticized for putting a cerclage in this woman, because people said, but hold on, the evidence suggests it doesn't work. Okay. However, actually, the Cochrane review had, I think, one RCT, very small, less than 50 pregnancies. And therefore, I don't think the quality of the evidence is very high. So what you really need to do is to have a proper study. But until that study is available, I would not advocate putting prophylactic cerclage in the first trimester for these pregnancies. Because it's an intervention, there's a potential complications, there's anesthetic complication and so on. So I don't think it's just a light decision to make. But IVF pregnancies, on the other hand, a lot of them are on progesterone, because the IVF clinics already started on progesterone. I don't know whether that works or not, but I mean, you could say, well, at least they are on progesterone. If progesterone does work, that maybe one potential intervention that you're offering them. Don't know whether people agree with that or disagree. It's a difficult area. For the other hand, I mean, perhaps probably Professor Romero might actually discuss that tomorrow. For the emergency cerclage, that's a completely different story, because there is evidence in Singleton from randomized controlled trials, small one, about the fact that it's effective. It prolongs the pregnancy. In twins, there's no randomized controlled trial, but there is evidence from observational studies suggesting that putting an emergency cerclage in women presenting with open cervix or very short cervix might be beneficial. Okay? Oh, sorry. You need the microphone.
I just have one comment from your last couple of slides. That was the BMJ meta-analysis about the timing of delivery, and the bit that NICE says about weekly surveillance. Yes, we can offer them weekly surveillance, but it's actually very difficult to quantify what is the risk of stillbirth.
Yeah.
For beyond the gestation that is proposed.
Yeah.
I recently had a woman who was 46. It was her third pregnancy. She was chronic hypertensive with MCDA twins, who wanted her and who didn't want to be induced by before 38 weeks. So she said, I want to go to full term. NICE says 41 weeks. Why am I different? And she quoted your paper, and I was like, okay, this is interesting. I spent a lot of time with her, and I said, well, actually, that is MCDA twins, but what about your own background risk with your age?
Yeah.
You also have
46.
an additional risk of stillbirth.
Yeah.
So she said, can you give me my tailor-made risk? And I said, I couldn't.
Yeah,
so every
we don't
time I would
have.
scan her, I was hoping that there was an abnormal Doppler and I could section her before.
Is that monochorionic or dichorionic?
Monochorionic.
Oh, she's brave.
Monochorionic, and she had a posterior uterine perforation with a Mirena coil. So she wanted a vaginal delivery with monochorionic twins beyond 38 weeks.
What happened? Did you make up a reason to deliver?
I was inspired from Andy, and I had normal biometry with one increased PI of umbilical artery, so I sectioned her.
And the babies are fine.
Babies are
Perfect. Fantastic. Okay, any other questions? I think we got everything from the streaming. Great, so I think we're going to go for lunch.